Hello, everyone. Welcome to Advanced Care Planning with Dr. Liz Anderson and Dr. Deborah Waldrop. I'm Peyton Smith, coordinator for the Coalition for Supportive Care of Kidney Patients. Before we begin, just a few housekeeping items. For clearer reception, attendee lines have been muted. We encourage questions throughout the webinar and ask that you use the chat feature on the right side of your screen to submit questions. When submitting a question via chat, first, type your comments and questions in the text box. Second, choose all participants. And then third, press enter. We will attempt to answer all questions during the presentation as we may not have time for questions at the end of today's presentation. At the end of the webinar, as you close your webinar screen, you will receive a pop-up evaluation. We greatly value your feedback. And finally, all webinars are recorded and will be posted to the Coalition's website at kidneysupportivecare.org in the future. Dr. Dale Lupu is serving as our moderator today. She is faculty at George Washington University School of Nursing. Dr. Lupu is the principal investigator on the Pathways Project, a Moore Foundation grant project to integrate supportive care into the treatment of patients with advanced CKD and ESKD. I'm going to turn it over to Dr. Lupu now.
Great, thank you, Peyton. So I have formal introductions to read to introduce Deborah and Liz to you, but I'm calling them by first name because they're both very dear colleagues. And I want to just very warmly say how much I admire and respect the work that both of them are doing to advance finding out from people what they really care about. That's what advanced care planning is all about. So Liz Anderson is an LCSW, DSW. She's assistant professor of social work at Western Carolina University. She practiced as a hospice and palliative care social worker, a bereavement coordinator, and the social services director for the Mid-Atlantic Renal Coalition. So that's where she got her experience in terms of dialysis and what it's like in dialysis centers. This isn't her formal thing, but I know from her background, she was the one who took all of the complaints that patients were submitting about their dialysis center. Dr. Anderson is a 2018 Sojourn Scholar Award recipient through the Cambia Foundation. Her research is in the area of supportive care for patients with kidney disease. She has created CKD-specific advanced care planning patient education material and the curriculum guide with a focus on trans-theoretical stages of change model and motivational interviewing. That's the guide we used in the My Way project. She is passionate about how to empower healthcare teams to provide the best patient-centered care and supportive care by infusing social work skills with a focus on empathy and evidence-based communication skills training. That's Liz's background. And Dr. Waldrop, Deborah. Deborah Waldrop spent 20 years working as a medical social worker in a variety of healthcare settings, beginning with dialysis and including acute hospital, long-term care, and hospice. She earned her PhD in human environmental sciences with a specialization in gerontology in 1999 and has served as a professor in the School of Social Work at the University of Buffalo since that time. She teaches courses in health, aging, loss, and grief, and is developing a micro-credential program in serious illness care for MSW students. Deborah also conducts research on healthcare decision-making and end-of-life care. Her guiding aim is to make change in the way we care for people who are seriously ill by preparing the next generation of providers and by conducting research that contributes to knowledge development and dissemination about this critically important time and experience in life. So Liz and Deborah, we're eager to hear from you about advanced care planning for this group of patients. Thank you.
All right, thank you. So hi, everybody. I am Liz. We thought we would just take a couple of minutes to start out and tell you a little bit about sort of how we got here today. So I went into social work, probably like many people. I thought that would be a great vehicle to figure my family out. And after a few classes in, I decided I probably ought to have some other goals. And actually, I really wanted to work with HIV and AIDS patients. And in my MSW program, I was placed in a field placement with a hospice in Richmond, Virginia, which is where I found out that I really was passionate about taking care and supporting patients and family members through really deep suffering and chronic illness and life-limiting illness. As Dale mentioned, I went on and I worked after that for the ESRD network. And one of the things that sort of came to me when I was in that job was I talked to so many patients and caregivers and providers about the suffering of patients with kidney disease. And I heard a lot of stories about how hard it was to address that. And it's something that I just really became passionate about. There were three things I think that I really heard from patients, caregivers, and providers. And that was one, providing this type of care is really hard because there are structural problems. There are issues with policy or, the way dialysis facilities are run, that kind of thing. And then I heard, some providers say, I really want to do this, but I don't feel like I've gotten enough training in that. And then the third thing that I heard that has always resonated with me came from providers and from caregivers. And that was, I care so deeply about these patients that I don't know that I can have this conversation. I don't know if I can talk about this because I don't want to hurt them and I don't want to upset them. And that really spoke to me because I think that, a lot of times all of us are in this medical field because we do want to alleviate suffering. And you all in particular are spending an awful lot of time with dialysis patients 3 days a week, and you establish those relationships, etc. So as I have moved along in my career, I'm sort of in this place right now that I'm like, how can I use what I've learned from my own practice experience? And how can I keep learning and share that information so that we can together work to alleviate the suffering of patients with kidney disease. So today, what we both will share, and I will let Deborah speak for herself, is we're going to share a little bit about what we've learned from our own experiences, what we've learned from the research, and what we're still continuing to learn. So you will hear some quotes today. These are real patient quotes that we've both collected. And we're just hoping that this presentation will give you a little piece of the larger puzzle and how we alleviate. So over to you, Deborah.
Okay, thanks, Liz. So my story is that I always wanted to be a professor, but I wanted to be the kind of professor who could teach from the real experience of being present with families. And so I spent the years in healthcare. As Dale mentioned, my very first job was as a dialysis social worker. But throughout the time that I worked in healthcare, I spent a lot of time with families who were trying to make decisions between really bad and worse options back in the day. And it was well before the Patient Self-Determination Act had come into being. And so there weren't vehicles, there weren't mechanisms for us to understand what people wanted. And some of the worst moments were when families would say, I don't know what to do. She never told me what she would want in these moments. And so that fueled me to really find ways we can take better care of people. And I went back to school in my mid-40s. And while I was in school, I discovered the joy of being a hospice social worker. I worked per diem. And I learned from the experiences then what hospice could do and what end-of-life care, a real attention to that, what difference that made as people were transitioning. And everything that I learned, I turned into my research questions, and I turned into fuel for my teaching. And so now I bring all those families, all those words I heard at the bedside and I heard as people were dying, into this idea that we can make a difference if we understand how people want to be talked to and educated about their conditions. And over time, I've spent a lot of my research work with hospice, but more recently, I've become very aware of the fact that advanced care planning can be very different when you look at a cancer patient, or you look at someone with Alzheimer's disease, or you look at someone with end-stage renal disease. And so for me, the new frontier is that we really need to craft and shape and learn from people on different disease trajectories. And so hence, that's what I'm working on right now, is figuring out in end-stage renal disease how we have the conversations differently across the trajectory of the illness. Because in the end, it makes a huge difference in the way people experience their illness as well as their families. So it's a pleasure to be here with you today. And I want to go ahead and move to the next slide, and we'll start by telling you what we have in mind for our goals today. So what we would really like to begin with is to define advanced care planning and consider it as a multifaceted, dynamic process rather than a stochastic one and done. You completed a healthcare proxy, so you're good. We see it as a much more dynamic process that occurs at more than one point along the trajectory of ESRD. We also want to discuss how, when, where, and who initiates advanced care planning in dialysis and before it begins. And then thirdly, we'd like to describe the triggers that may signal the need to involve a social worker when life events may really have a significant impact on someone's goals of care, and those goals may be changing. So that's our plan for today. And
so I start with this comic strip here. I just really like it, but real strengths perspective. First of all, I want to applaud you for your will to go on living. We, in this interesting new web format for both of us, we really wanted to have a way in which we could hear a little bit of your voice. I actually am not going to be able to see your comments, so I've got Dale and Peyton who are going to chime in, but we want to hear a little bit about how much experience you have from your perspective in the dialysis unit with advanced care planning. So if you could just use the chat bar to tell us a lot, some, or little. We're not collecting this information. It will not be affiliated with your name. We just want to get a sense from those of you that are here what your experience is like with advanced care planning. So if you can just take a second and maybe also, when you're using the chat feature, apparently you can choose if you want it to be shared with everyone or just one of us, which would probably be Peyton and Dale, because they'll be able to see that.
Hello, Liz. I've been getting a few responses. So we have one person saying some, about 4 saying they have a lot of experience, 1 saying a little. One person said, very good experience. My doctors are very involved and supportive. Another respondent said that they are a huge advocate of advanced care planning and have been a renal social worker for 4 years, and feels it is important to have a plan.
So I'm going to get you all to answer 2 more questions. So if you could type it in the chat box, that would be amazing. If you're calling in from a phone, maybe just jotting it down just to start thinking about it. What characterizes a good conversation with advanced care planning from your perspective? And likewise, what are maybe some difficult elements of that? If you could just take a couple of minutes to jot those down.
I will just read a few off, just in case you guys haven't been seeing them.
Okay.
So helps helps and established relationships and a privacy for the discussion, coming from a place of compassion, quality of life and goal focused are all what characterize a good conversation, gaining a basic understanding of the patient's understanding of advanced directive options.
And some things that hinder it, make it difficult: high patient load, lack of privacy on the unit, patient ready but family not ready to have the conversation, or vice versa, family ready and patient not.
A lot about readiness. Okay, perfect. So I'm hoping that we'll be able to touch on some of these as we go. These are all things I think that we've heard and we're going to try to hit on. And if not, we also are going to lend you all some resources where you can learn more as well, since we only have an hour.
Some other responses continue to come in. Please feel free to keep chatting as we go.
Okay. Yes. So we wanted to start off by distinguishing what really is advanced care planning and how is that different than regular care planning? How is that different than shared decision making? I actually think Dale created this graphic here, and the care planning needs to be moved up, and that's my fault. But you can see from the graphic what we're saying is that advanced care planning is part of the larger care planning umbrella, and shared decision making is also part of that, and there is some overlap between shared decision making and advanced care planning. But really, for the purpose of what we're talking about today, advanced care planning is what we do, and you can see it underlined here, to understand and allow patients the opportunity to share their values, their goals, and their preferences regarding their future medical care, particularly if they're not going to have a voice in that. So today we're going to be talking about how we can elicit that, talk about that, and document that. So that ultimately patients can get the care that they want at the end of life. Advance my slide. This happened earlier. Oh, there we go. Okay. So we want to just spend a few minutes talking about why this is important. And actually, this happened to me earlier. Oh man, I keep going. There we go. Getting control of the keyboard, I'm sorry. So why is advanced care planning with dialysis patients important? And you all probably could preach this, but just to reiterate that one, patients that have kidney disease do have a higher incidence of heart disease, strokes, and dementia. So we know that there are other factors that come into play that can impact their health later on. We also know that patients that are on dialysis are more likely to be hospitalized for longer. They're more likely to end up in an intensive care unit and just have high intensity treatment. And so these are times when those conversations become really important. In addition to that, just data from the USRDS that higher mortality rates and a limited life expectancy that is shorter than the general population. So we know there are health issues that lend themselves to these conversations. But we've also had some research come out in the last 10 years that have told some other stories from a dialysis patient's perspective. So some of the research suggests that up to 61% of patients regret the decision to ever start dialysis. So patients kind of saying towards the end, I'm not really sure this is what I would have wanted. And then in addition to that, patients, when they're really queried in depth about what their wishes are, and this kind of goes back to some of the things I saw you all type in, that quality of life is really important, and patients saying they're willing to lose as much as 7 months of their life expectancy if it means that they don't have to go to the hospital as much, or they're willing to lose as much as 15 months of life expectancy if it meant that they could travel more. So that people are willing to make some trade-offs in order to engage in that quality of life. And so, us in the medical profession, we're so focused on, how do we make the illness better, when, on the other side of that, oftentimes we have patients saying, I care about the illness, but actually these other things are more important to me. So that's another piece. And then, the statistic that 50% of patients want to die at home. So patients expressing that desire, hospice is vastly underutilized in this population. And I think I just saw day before yesterday a statistic that said patients on dialysis, about 20% of them end up with hospice at the time of death. So again, So just from a sort of historical perspective, when we first started talking or mandating advanced care planning in the healthcare arena, it began with the 1991 Patient Self-Determination Act. And in that act, all these healthcare organizations were identified as being required to inform patients about their right to have a living will and an advance directive. However, when that legislation was written, dialysis facilities were not included in that. And so in 2008, the Code of Federal Regulations for dialysis facilities was actually changed, and it was the first time since dialysis began that dialysis facilities were required to inform patients of their right to execute that advance directive or to discontinue treatment. And as you all probably know, that Code of Federal Regulations also said that dialysis facilities had to reassess unstable patients, and I've quoted that here, in certain circumstances. So, after frequent hospitalizations, if their health has deteriorated, etc. What the code didn't tell us, though, is how to go about doing that. So we know that it has to happen, but the how-to is not covered there. And so that's part of what we're going to share with you today. So before we get into that, just recognizing and giving a head nod to what some of the barriers are. We've talked briefly about that. But one of the barriers that we hear is that nephrologists often report that they haven't had the training on how to initiate these discussions, and they aren't comfortable having those discussions, which I think is a really valid statement from providers, because often training programs aren't including that element. Yet what we're hearing over and over again is that patients want to be given all the information about treatment options, including withdrawal. Just on a side note, I've been engaging in my own research on rural patients with kidney disease, and I've done these qualitative interviews. And in the first 8 that I went through with patients, I just started kind of keeping track of how many patients said, literally, I want to know everything there is to know, even if it's ugly. Of the 8 that I've been through, 7 of them explicitly said they wanted to know everything. So we know that patients want that, yet we also know that that is something that's hard a lot of times for providers. And so I have this quote here from one of the patients I interviewed this summer. I want to know the truth, and I want my family to know the truth because I don't want any surprises to come up. The other piece of that is, I think that one of the things that we're hearing as a barrier is the fear that patients are going to express negative emotion. And the fear that patients are going to cry, and the fear that if we make patients cry or we tap into that negative emotion, that we have done something wrong and we need to make it better. What I think many of us would say to that is the negative emotion or that fear and that sadness is already there. And so part of it becomes, do we want our patients to sit with that fear and sadness alone, or do we want to journey with them on this and sit with them through that? And so again, I've got a couple of quotes here, and I'm going to just be quiet for a second and let from patients I interviewed. So, I think the point that we're trying to illustrate is that patients are carrying around these stories anyway. It's the pink elephant in the room. And one of the things that we talk about when we teach trauma a lot of times is one of the hardest parts of trauma is that people who are traumatized are silenced. They're not allowed to share their story. And though I don't think that dialysis is a trauma, I think that sometimes people, when they don't have a chance to tell their stories, it's like they get stuck in their head too. And so being able to explicitly talk about it sometimes helps with that process. Okay, I'm moving it over to you, Deborah.
Okay, so for this next part of the webinar, we're going to talk about the nuts and bolts, the who, when, where, how kinds of questions. And I just want to cite that the material we are presenting, we've adapted from a really excellent article by Ernest Mandel and his colleagues at Harvard. And I think it provides us with a framework that at least helps us ask the questions and maybe deal with some of the issues that are really, really critical to making this a successful process. So when should advanced care planning conversations be initiated? And I think the question that is addressed in this framework is, should it be before, during, or after a treatment? And I'm talking about when, in the space of a day, when someone comes to the unit, when would you be doing this? Would you want to meet with them before they started treatment, during treatment, or afterwards? And I think each of those elements bears its own barriers and challenges, in the sense that people have to spend extra time if they have conversations with you before or after a treatment, and they may not want to spend any more time there. And during treatment really begs the question of how well can you provide, and one of the chat comments addressed this too, how well can you address privacy? I think another temporal issue is, how often, how frequently should these conversations be initiated? And the question is quarterly, biannually, or only after something has happened. For example, they have access trouble, or they lose an access, or they're hospitalized for some other acute medical crisis. At those points in time, is it possible to reevaluate what the person is wanting? And I think that considering a patient's self-determination is really important. Patients may want to, again, not extend the time, or they may have transportation challenges. In my experience as a dialysis social worker, that was the biggest problem that way back in the day, that it couldn't getting people to and from. And they also may be unable or unwilling to have a conversation while they're on treatment. So really thinking about what's best for them and allowing them to tell you what's best. But I'm a firm believer that when there are medical crises, it should be reevaluated. I'm also, I tell people all the time, it's like changing the batteries in your smoke detector. We do this on New Year's Day every year. There should be regular times when we just come back to say, are these the same? Are these the same wishes that you had? Because with aging, with the comorbidity of other conditions, things might change and we don't even recognize it unless we ask. So can we move on to the next slide, please? So where? What is available on your unit? You know better. If it can be a private space, if you can somehow guard for sound. And so even beside the dialysis bay where people are for treatment, there may be an office space, there may be a waiting room that you could incorporate a private space quickly before a treatment or afterwards. And I don't even think I want to emphasize quickly, because I don't think these conversations need to be hurry up. I think, but a quiet space might be what's needed. And then, is it possible, even if you do it on treatment, is it possible to guard confidentiality and privacy? And then I think sometimes it's maximally efficient to have conversations during treatment, but then you run the risk, as you well know, of the distraction of treatment-related problems like blood pressure crashes, or there's leg cramps going on, and that it abrupts the flow of your conversation. So there's a lot of issues in this population that are harder to deal with than other kinds of chronic illnesses. And I think just thinking about these questions ahead of time at least gives you a quality check on what's available in your unit. And who? The question is always, who should initiate? Is this the role of the social worker? Is this the role of the nurse or the doctor? And our contention is it's any member of the team can initiate these conversations. And we think it's better if it's initiated from a multidisciplinary perspective, because the patient and or the caregiver or the family member may have different questions for a provider, for a nurse, than for a social worker, and different aspects of the conversation may come into focus differently with different professionals. So we are big proponents of everybody should be participating in this. That said, we don't want people to bump into each other, but it's okay if other people, if more than one person is raising some of these questions. When a social worker introduces the topic, the approach can focus on the synergy between what's happening in someone's life related to the medical condition. So what are the psychosocial impacts that are a result of this medical condition? And then documenting the outcomes will help other team members know if this conversation's been initiated or the patient has asked questions of different disciplines. If it's in the EMR, then everyone's going to be aware of what the person is wanting, and it can really make it more effective and more efficient for interdisciplinary care. So what is the content of advanced care planning? And basically, it's here are the building blocks as we see them. It's patient understanding of their illness. It's informational preferences. How do they like to receive information? Do they understand written material better? Would they process it better if they heard it? I don't know what the current statistic is, but I think how much of what's spoken to us do we actually retain? It's something like 60%. I deal with that in the classroom a lot. So how can we best be giving information to patients, and how much do we give at one time? Perceptions of prognosis. This is something I've run into squarely in the work that I do as a researcher, in that patients don't get a prognosis. Their diagnosis is end-stage renal disease, but that isn't necessarily paired with what that looks like in terms of life expectancy. Now, we also should be emphasizing that we want to work within the scope of our licenses, and social workers will not be giving out medical information, but they can address and assess what the person understands about his or her prognosis. And they can also assess and address the complications of multimorbidity, when so often our patients have multiple diagnoses. So figuring out what each of those diagnoses is doing and how they each contribute to the uncertainty. Asking what goals the person holds most dear, and that isn't just what would you want us to do if your heart stops, but it is medical, but it's also what are your personal goals? What are your social goals? What is it that you would hope for, wish for? And I like to think about it as whole life goals. So you want to watch a grandchild graduate with her degree in May, or you want to hold a grandchild that's being born. There may be other goals that are equally as important as medical goals. We also want to not shy away from, as Liz said, allowing people to talk about their fears and their worries, both medically, emotionally, psychosocially. People are often more worried about their families than they are about their own well-being. We want to identify sources of strength and coping. So what's worked for you in previous other stressful, particularly medical situations? How have you coped with the challenges and the changes that have come up with a diagnosis? What is acceptable or critical? What can you tolerate and what can't you tolerate? What trade-offs could or would you be willing to make? And that's, I think, a really important question, because people are willing to choose something if they know they can have something they want is really important to them. So helping people identify what that is. I think we should be always asking, how does your family understand and deal with your illness and treatment? The unit that I'm working with now, families don't come in and sit with a person while they're in treatment. So I wonder about how much families really grasp of what goes on during a dialysis treatment. And I think we need to find out what families are understanding, because they're an equal partner in the process. And there's a reciprocity that goes along with what happens to the patient happens to the family. It reverberates through the family system. And then finally, we want to ask how involved family members are. And they may be squarely involved, solidly there, or they may have a lack of understanding about how much is really needed. And really understanding from the patient's perspective how involved their family is an important thing. And so how to have the conversation. How we have the conversation really, this is still me, right, Liz? Yes, it is, okay. How to have the conversation is really breaks down to words matter. How we have it, how our aura, if you will, the way that we approach it with respect and care, or if we're rushed and hurried and we want to just check a box off that we've gotten a healthcare proxy completed, that's going to really shape and make a difference in how it goes. I think how patients perceive our emotional reactivity or reaction and our ability to simply be present. Next Monday, I teach my aging class on end-of-life care, and I told them that the prequel is the two things that are most important in all conversations are, one, to be present, and one, to bear witness. And so I think those are really key pieces about an advanced care planning conversation that goes well. And then we have to be working at the top of our license, at the top of the scope of practice by listening, because the patient's going to give us a lot of cues. And I think we should not be afraid to ask if a cue is, I don't want to talk about this now. It's okay to gently probe that a little bit and find out what is behind that. So that's the where, what, how, and who part of our presentation.
Okay, thank you. And I'm going to look at the clock here. All right. So I think a lot of really important material. One of the things that I was thinking of as Deborah was going through this about, listening for patients' cues, not being afraid to lean in and have this conversation is one of the phenomenon that used to happen to me when I worked as a hospice social worker. That here in the South, and I can't speak for social workers across the board, but there was sometimes, people would be like, oh my goodness, you shouldn't tell people that you're a social worker. They're going to think that you're, there to take their children away. And then there became the whole, well, you can't tell people that you're in hospice because they're afraid they'll find out that they're dying. And so I would go into these patients' homes with my name tag on, and the caregivers would rush to the door and they'd say, oh, Liz, you got to turn your name badge around. Don't show the patient that he's dying. If he sees hospice, he knows he's going to be dying, and he doesn't know he's dying. And, talking about, you all talked about readiness and kind of gauging that readiness, especially if it was, first time I met the patient, I'd be like, okay, I'd walk in the room with the patient, shut the door, she would look up to me and say, listen, don't tell anybody. They don't know it, but I'm dying. And I can't tell you how many times that happened, and I would have this conversation like, oh, but I think maybe there's some ways we can talk about this together. And so what would happen was the family was having all of this stress because both parties knew something was really, really wrong, but they couldn't talk to each other. And it would be just this exhale when that would happen. So anyway, I just wanted to add that piece. All right, how to have the advanced care planning conversation. I was going to ask some questions now, right? So we're just curious from you all. We want to pause for a second and ask, are there any examples that are relevant in your area here? Thoughts, questions, or ideas that you would like to type in that we can maybe address? So we just wanted to poll you and encourage you to offer any thoughts, questions.
As people are typing, just to read two that came in on the chat earlier, something that's difficult elements I've experienced are helping the patient understand the importance of this. And then another thing that's difficult, I find it hard to help patients who think by stopping dialysis they are signing a death warrant. So those were two difficult.
Can you read that last one more time, Dale?
I find it hard to help patients who think by stopping dialysis they are signing a death warrant.
Okay.
That's about the decision to stop.
Yeah.
And another difficult thing, when the family members disagree with the discussion. So a lot around family and how do people understand about the situation.
Yes. And so, I think we're going to talk in a minute about readiness, just to address a couple of those things. One thing I think we have to remember about advanced care planning is advanced care planning can be, I want every single treatment in the world, no matter what. And that is okay. Our job in doing advanced care planning does not have to be to convince somebody to stop all treatment. I think, going back to the questions that Deborah presented, it should just be a conversation about, are there going to be times that it's not going to be worth it for you anymore? What is that going to look like for you? And really helping people have that discovery, because if somebody just came to me today and said, well, Liz, what do you want? If you have advanced kidney disease, it's really hard for me to answer that unless maybe we talk about some of those other circumstances surrounding that. Well, if it means that I can't talk to my family ever again, or, if I can't, if I'm going to live in pain, that sort of changes some of that. The whole family issue, when families disagree, I do think can be really challenging. And I think, at least from my perspective, that's an important place to pull in social workers, because that's, part of what we as educators do is train social workers about family theory, family systems theory. And, what are those dynamics and what are those skills that we can use to kind of help people come together to establish a common goal, et cetera. Are there other?
I
Go ahead.
received one, and it kind of goes into what you were just saying, and it was the difficulty with dealing with issues of dementia when patients cannot make the decisions and families are unwilling to play God, in quotes.
So it sounds like situations in which the family's not willing to make any decisions and just wants to continue on that trajectory intervention. Yes. And I think in those situations too, the other piece is really empowering our team together to come together, involve, ethics conversations, and that kind of thing. Deborah, do you have anything you want to add to any of those?
No, I think we're good here.
So I'm going to attempt a technology leap, y'all. So bear with me. So I want to share with you all 2 resources that are available for free that are, we're not going to have time to get into the details of all of these things, but I think we'll begin to address some of the questions that have come up. So let's see if I can do this. Whoops. Well, darn it. Yeah, I'm going to stop sharing just for a second. And let's see. Give me 1 second. I want to take you all to the Coalition of Supportive Care Kidney Patients web page. I'm going to do that right now with my. Okay, so this, if you Google the Coalition of Supportive Care of Kidney Patients, that is who's sponsoring this, you can find 2 important resources related to advanced care planning. So if you go under patients and families, and hit advanced care planning, you will see tools. But the one that we developed through the My Way project is this one right here, Planning Today for Tomorrow's Healthcare. And so this is a 10-page brochure designed for patients about advanced care planning. And it goes through this 5-step process of what a patient would need to do in order to complete an advanced care plan. So it's a step-by-step. It's written at an 8th grade level, or maybe under that. I can't remember. And it gives them all kinds of information related to that. So this is a tool that you can use to provide patients with information about advanced care planning, or to provide their caregivers with that. And it has a little worksheet at the end that they can fill out. Going back to the coalition's page, if you go under professionals and go to advanced care planning, we developed a curriculum guide. And so this is a guide for you all as professionals, and it is grounded in motivational interviewing, which I'm sure many of you are familiar with, but it is really how to have a conversation with patients about advanced care planning. And it's meant to be a very flexible approach. And you can look at it in more details, but it goes through some of the motivational interviewing tips. But it also illustrates, kind of a step-by-step process, understanding that everybody's process is going to be different because one patient might have an advanced care plan and one patient may have never heard of it or be resistant. But I think the important thing to say about this is that that as you all have already stated, really knowing who's ready, that we do these conversations based on their readiness. But we don't start the conversation with, do you have an advanced care plan, or do you want CPR? We start it with, tell me a little bit about your diagnosis, and have you ever been through anything like this before? Allowing people the opportunity to have some dialogue about what their fears are about their future health, and allowing us the opportunity to reflect a bit on that. So I'm not going to go into more detail there. I could give a whole another presentation on that, but I would just encourage you to check those two resources out, as they might be good guides as well. Now I'm going to go back. I'm going to share the PowerPoint again. Slide. So those materials are here. So when we do the advanced care planning, so the next part we're going to talk a little, is this my slide or your slide, Deborah?
Yep, you do the next two.
Okay, I do the next two. Thank you. So when do we need to, we have 13 minutes too. Great. When do we have these conversations? I think one of the hardest things in a dialysis facility, is probably okay, we're making this shift and we're going to be more intentional about doing it. And in my mind, a lot of these conversations can really happen as part of the initial assessment. Like, what does this illness mean for you, et cetera. So places, though, that we've identified that are important to have these conversations are obviously before patients come on dialysis. You all might not have control over that. But certainly more and more we're looking upstream. When dialysis is started, post-hospitalization. So, and just on a side note, all these interviews that I've done with patients over the summer, just so many of them talked about when I went to the hospital and I almost died. So it's a great opportunity to, again, be listening, like Deborah was talking about, for what are those cues that they're giving us after access failure and when they're considering withdrawal. So what are some things we might hear from patients that signal to us that it's a good time to have these conversations? So again, all of these are real patient quotes. How am I progressing? I'm pretty standard, right? So we have a patient that's asking, wanting a positive answer. They're sort of teetering on the line, but they're really curious. And so again, just sort of leaning into that. Tell me a little bit about what you think that's like. It sounds like you might be a little bit concerned about your progression. Talk to me about that. Another patient, on my bad dialysis day, I sometimes pray that God will take me. This is something, again, that emerged in some of my own research. Some mornings when I wake her up for dialysis, she says to me, why go to dialysis? I'm going to die anyway. This is just in existence. So that was a caregiver that told me that. So these are all moments where we can kind of start to talk about, sounds like you've got some really big fears about the future, heavy stuff going on. We can have a conversation about that.
Okay, so I'm going to take it from here, and we're going to illustrate the framework that Liz just presented a couple slides ago with the different stages of the trajectory, and we're going to illustrate that with some quotes from our work to help you operationalize how you might be able to initiate and what might initiate the need for conversations at these different stages. So before dialysis begins, the question I always have about this is, who has access to a patient who sees that person before they initiate dialysis? And from my work, I've really discovered, and this is not, I'm sure, news to any of you, there's really a bifurcation of the trajectory before dialysis. And sometimes it's a sudden, just like that, the hypertensive crisis or diabetic crisis has kicked the kidneys out, and so they are no longer working. And so for or sometimes it's a very long anticipated one. And one of the people that I interviewed was 33 years old, and she'd been diagnosed at age 10 with very brittle diabetes. And she said, my mom always told me I would end up on dialysis. So imagine this then 27-year-old, when she started dialysis, what was going on with the narrative in her head was about that life experience from age 10 forward. Or the 80-year-old that I interviewed last summer who said, his mother and sister had both died on dialysis. And he said, I expected this would happen someday. And about a year ago, my numbers started to decline. So there was this pre-existing idea that dialysis was in the future versus the sudden crisis experience where a 25-year-old needed a physical just to play basketball. He was in college. And he said, my blood pressure was so high, they sent me to the emergency department and they found out that my kidneys had shut down. Imagine that, going from the basketball court to the dialysis unit. And then I think at this stage, whenever we might encounter someone in a long and anticipated trajectory or a sudden crisis situation, we want to not forget about the family. What do they understand and what are they expressing at that stage? Okay, thanks. When dialysis is being initiated, I remember this only very well from my years back in my time as a dialysis social worker, how potentially traumatic that initiation could be for people. So there are really two parts to this that I think we have to focus on. Cognitive. So one of the patients that I interviewed said, I thought dialysis was like a nebulizer. You only have to have it when you need it. So no understanding of the fact that it's this regular 3 times a week occurrence. And, so really stopping to say, tell me what you understand about that. And then behaviorally, this was from my days in practice, we had a 19-year-old who came into treatment with one of those 7-Eleven big gulp cups and a bag of potato chips. And the nurses were very frustrated with that and said, what about this don't you understand? And so that was a perfect opportunity to stop and say, tell me what you understand about this prognosis and this diagnosis. And again, thinking at this point, what does the family comprehend? Is there increased need for family involvement, either in transportation, caregiving, what have you? Okay. When somebody's hospitalized, it's a game changer. And so when there's an access failure, there may be a need for a modality change. It may be time to revisit goals of care. In a medical crisis, there may be a decline that's happening. There may be an additional need for assistance or caregiving. There may need to be conversation about placement. But my question is always, can the dialysis unit social worker go into the hospital to see a patient? Because what I've heard from people is that continuity is really important. They get very close to and very comfortable with the people who treat them every 3 times a week. And now suddenly in the hospital, they may not have access to those people who've been so critically important to them. So that's a question I think for organizations to answer. I think addressing discharge planning needs, being sure to connect with the people in the hospital who are going to be making those plans so that they understand the history. And then really stopping and taking a look at what's happened because of the crisis. And what is your understanding of what lies ahead for you, helping people put into words what they know, what they understand. We want to be sure, again, to consider what the family needs or is expressing at this point in time. It can be a scary time, and so finding that out. When there's a transplant failure, transplant's often held out as the gold standard of care in many situations. But sometimes when the transplant fails, it's a real crisis. And so I think one of the key questions at this phase is attribution. What's your understanding about what caused the kidney to reject? Was it that the person wasn't taking paying attention to diet and meds, how to help the person who slipped a bit, and how to help the person who was very diligent and the kidney failed anyway. Because making meaning of this and understanding what it means for the future and how it might shape goals of care is a really critical piece. And then modality change follows usually. People go back to dialysis. And so re-entering the dialysis world and starting that all over again brings back a lot of feelings and perhaps another time to really consider what's wished for. These can be very life-changing events, and really thinking about how it changes their perspectives and their goals. And again, how does the family comprehend it, and how does the family understand it and express it? And then at last, when there's a withdrawal consideration, the whole idea that it could be a death warrant, really putting into words what it is people fear would happen, really asking what their understanding is. We still need the team members to care and not suddenly be out of their lives. We need to think about, is it time to contact hospice and involve them? Where does the person want to be at the end of life? Where does the family want that person to be at the end of life? And how might we best involve palliative care, a palliative holistic approach to this person who will be reaching the end of life soon? And again, consideration of what the family's wanting and needing. Is there congruence between, and someone mentioned family conflict, is there congruence between what family members are expressing and what the patient wishes? And how do we operationalize the principles of self-determination, allowing the patient to choose in a context of conflict, perhaps? Thanks. And that ends my part, and I think Liz is going to wrap it up with some questions, comments, and discussion.
Outstanding. So yes, y'all probably might have heard my alarm go off. I think we have 3 minutes. So we know that we just sort of scratched the surface of a lot of bigger issues, and I think there's some great explicit questions out there, like advanced care planning with a patient with dementia and those kind of things that are going to need to be future areas as well. But just for now, in the last few minutes, are there any questions that Dale and Peyton, have people typed in any questions or comments, things that we can address?
No questions in the chat at the moment that I see.
I haven't received any as of yet.
Well, we are so grateful that you all were here with us. Looks like Dale has just shared the coalition's website. Again, there are a ton of other resources there as well. We'll make this available, but we just appreciate you all being here and your attention to that. Attention to advanced care planning and all of the work that you all have been doing to alleviate patient suffering as well. So
maybe if you change the slide to our contact information, and
right, thank you,
people
appreciate that,
to let us know if there are other ways we can be helpful.
Yes,
I'm so glad both Deborah and Liz, thank you for presenting, for making yourselves available. I would just reflect that I liked that you didn't present this as a, here's the list, do this, 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 and this, but you were, I think, coming from your social work background, but much more a sense of how do we open the topic, how do we open discussion. So one thing and we have 1 minute left, do you want to address the question of time? Because everyone in the dialysis center is so busy, they don't have time.
yeah.
Respond to
Yeah. So I think absolutely it is a reality, and I think I always come from this very organic place of, listening out, listening for those cues, knowing that if I address that early on when it emerges from a patient, that I'm not going to end up spending the time on the later end with that. I do think, and Dale, you might know the research better than I do. I mean, there's some new studies that suggest, a patient-centered care visit adds, maybe 5 minutes to initial interviews. Advanced care planning being done in shorter bursts of time is, a reality. I mean, I think that there are organizations that can successfully do that, but I think some of that really has to be about being able to have some flexibility and fluidity in our own assessments with patients and being able to address those concerns as they come. Ultimately preventing those kind of crisis conversations that end up sucking up 90% of their time from emerging.
Thank you so much. We're at the end of our time. Thank you for your perspectives. Thank you for making your contact information available. On behalf
resources also listed that will be,
okay. So we will be posting the webinar, and you'll be able to see the slides and the resources from there. Will be available on the kidneysupportivecare.org website in a bit. Please look out for the newsletters and the webinars that are coming in 2020. And please, as you leave the webinar, there will be a pop-up of an evaluation form. These are really important to us. It helps us plan. So tell us what other topics you'd like, what other speakers you'd like, and how you're going to use this. Thank you so much. Thank you so much, and hope this was helpful and adds to your practice. Thank you.